Good evening. Hello. Welcome. Thanks for joining me tonight. I'm Dr. Isaac Gooding. I'm a board certified physician in anesthesiology as well as pain medicine. I newly joined Southeast Orthopedic Specialists. I'm here tonight to tell you a little bit about myself and my approach to pain and let you know who I am so that if you go see me, you have a little bit, be familiar with me a little bit before we start treating you. So what I'm going to talk about, my education, where I went to school, training, where I've done internship, fellowship, residency, what experience I have in both anesthesiology and pain management. And then we'll get into a little bit about my approach to pain management, what you can expect when you come to see my clinic, and then get into the specific treatments offered. There's a picture here. Some of you might notice this. This is Mount Rainier in Mount Rainier National Park in Washington. I'm a Pacific Northwest guy from Washington State, but couldn't be happier to have landed here in Jacksonville. So left Washington, I went to undergraduate college in University of Southern California in Los Angeles. At that point, I was on an ROTC scholarship. The plan was not always to do medicine. At that point, I was going to be maverick, join the Navy and be a naval aviator. But I quickly realized that I had affinity more towards those science classes and the medicine-related classes, and quickly changed my direction towards a pre-med course. Got my degree in exercise physiology and was soon off to New York Medical College in New York to get my Doctor of Medicine. Did my academic work in medical school in Westchester County, which is a little bit north of the city, and was fortunate enough to get to do all my clinical work in New York, which was a good experience as well. At that point, the military had paid for my government paid for my undergrad degree as well as my medical school degree. So it was time to give some payback, and I was glad to do it. You'll see a lot of Naval Medical Center San Diego in here. That's where I've done most of my training. I started out there doing my internal medicine internship in 2001, and then moved on to Naval flight surgeon training. In the military, you don't necessarily need to go straight through between internship, residency, and fellowship, especially in the Navy. They offer you the opportunity to do what's called an operational tour. And I chose to do that in between my internship and residency as a Naval flight surgeon. You go to Pensacola, learn about aviation physiology, aviation medicine, and become a flight surgeon. Nothing to do with surgery, but you become the expert to let the pilots and aircrew know when they can't fly, make sure they're safe in the air. I moved on to residency in anesthesiology in 2006 and fellowship in pain management in 2015. So one thing I can't complain about is the duty stations that I've gotten in the military. Between you've seen San Diego, Pensacola, but the first duty station I had after flight surgery training was in Kaneohe Bay, Hawaii, which was a great experience. All expenses paid trip to Hawaii for 3 years. This was the operational tour that I was referring to with Squadron, Patrol Squadron 9, VP9. And with them, I was able to deploy to the Middle East, deploy to Japan, and been a really good experience. I'm so close to a lot of those guys today. But it's time to continue on with my clinical training. Went back to anesthesiology residency, and then served as a staff anesthesiologist at Naval Hospital Camp Pendleton, which is northern San Diego. Still staying in that good area. San Diego, good spots. And during that time, I was able to deploy again. This time, not as a general medical officer, but as an anesthesiologist to Afghanistan, Kunduz, Afghanistan, where I was able to provide trauma care to our troops actually in theater, which was another rewarding experience for me. Finishing at Naval Hospital Camp Pendleton, I specialized in pain medicine, and the first duty station I went to was Naval Hospital Okinawa. There, I was the sole pain medical specialist for the entire Western Pacific region. What I mean by that is anyone west of Hawaii, whether they're in mainland Japan, Okinawa, South Korea, or any other detachments in that area, would come see me, and I would do my best to keep them in theater. We did a really good job. I don't think we sent one person back to Hawaii over that period of time. Following those 2 years in Okinawa, I came back to Jacksonville. I came here to Jacksonville, the East Coast, for the first time in my career. And I've been running the clinic at Naval Hospital Jacksonville at Naval Air Station for the last 3 years, providing comprehensive pain care for our active duty personnel. As I approach my 20 years, I put in my retirement paperwork and retired on September 1st, started with Southeast Orthopedics on September 1st, and here we are. So approach to pain medicine. Why are you going to go to the pain medicine doctor? Well, in general, there are some situations where we may see you on an acute basis. Acute disc herniation with radiating pain down your leg if we're trying to avoid surgery, or vertebral compression fracture, something along those lines. But in general, I'm going to see you for a chronic pain condition, something that's been present for over 12 weeks, 3 months mark. That's the textbook definition for chronic pain. Typically, you've tried some typical treatments and they haven't really responded, and you're going to be sent to me. And what can you expect me to do? Well, my idea is, my goal is through physical exam, history, imaging that we may order, and possibly diagnostic tests to find out what's going on, so I can improve your pain, improve your function. We focus on pain as the goal a lot, sometimes too much, and that's important. We want to reduce that pain, we want to reduce people's suffering, but function is what I really try to concentrate on. I want to get you back doing the things you want to do to the greatest extent possible. That number is just a number, but if you can get out there and play that game of golf that you want to play, that's satisfying to me, and that's our goal in treatment. So what are the ways that we can do that? There's 3 primary things that I focus on. The first one is that self-care conservative management. And what I mean that's the home exercise program that you're doing. That's the yoga that you're doing, core strengthening, stretching, physical therapy, chiropractic care, eating healthy, making sure you're getting the right amount of sleep. That's often hard to get a lot of buy-in on, but that's a very vital part to that comprehensive pain management strategy. It's very important. You can think that as the maintenance phase, especially when you're feeling good and your pain's not there. That's when you need to be doing those things to prevent those pains and those aches from coming back. Medication management is the next thing that I tend to look at. And when I say medication management, I do not mean opiate-based pain medications. Opiates have their role, but it's generally in very specific situations, post-operative pain, acute pain situations. For chronic pain, they just don't work very well and often can cause more harm than benefit. So when I'm talking about medications, I'm talking about non-opiate-based pain medications, neuropathic pain medications, gabapentin, Lyrica, different anti-inflammatory preparations, maybe some topicals, Voltaren gel, lidocaine patches, maybe some antidepressant medications are indicated to treat pain, Cymbalta, Effexor. So we're doing those things. And then the third thing is interventional treatments. I'm an interventional pain medicine doctor. I was trained doing various injections and procedures to improve your pain. So those are the things that I can offer you that other provider might not be able to. But in addition, these are the things that I think are going to give you the most dramatic improvement in your pain and get you back to doing those things that you want to do. So with that in mind, what specific treatments, what general treatments do I offer? What things do I give you? Well, there's a variety. We do a lot of injections, peripheral nerve injections, different joint injections, but being that neck and back pain are the most common reasons we would have someone come to our pain clinic, I'll go over some of our most common procedures. Epidural steroid injection, I'm sure you've heard about that or familiar with that or heard those words mentioned. Epidural steroid is typically more for radicular pain from an inflamed nerve radiating down your arm, radiating down your leg. Typically that would be from a disc herniations that's causing irritation to that nerve root. Sometimes spinal stenosis will respond to an epidural steroid injection. Sometimes discogenic pain can respond as well. All epidurals are not equal. There's different approaches that we can use depending on what condition you have. May determine which one I recommend to best treat your pain. There's interlaminar approaches. Those are direct into the posterior direction. There's caudal injections, and those both provide more widespread direction of those epidural steroid injections. And then there's transforaminal epidural steroid injections, where we deliver that anti-inflammatory medicine directly where we need it to go. And that can be very helpful for diagnostic and therapeutic values. Next most common procedure that we do that I would offer you are the lumbar facet injections. Sometimes you refer to these as medial branch blocks. Those are different procedures, but they both treat the same thing, and they're both primarily diagnostic treatments where we're going to numb up those facet joints. Facet joints are the joints in the posterior back. When you have spondylosis, when you have degenerative disc disease, those can start rubbing together and cause pain. What we do with the facet injections or medial branch blocks is numb those areas up. If that reduces your pain, confirms the diagnosis, then we can move on to nerve ablations or RFAs, where we can burn those nerves away for a period of time. It's not a permanent solution, but you can get years of pain relief with those injections. And the next thing I want to talk about is spinal cord stimulation, where what that is actually a lead that we implant into your epidural space. You can think of it more as an internal TENS unit, where we provide some stimulation to that dorsal column in the spinal cord. And by doing that, we can reduce back pain, leg pain, and really give you some good relief. That's more for patients who haven't responded to some of the treatments that we recommended, someone who's had back surgery and is continuing to have pain. And typically the protocol for that is I would do a trial where I implant those leads percutaneously, tape them to the skin. You wear them for approximately a week, give or take. And if it dramatically improves your pain, you decide if you want to go for permanent implantation. And if we do that, we'll send you one of our excellent spine surgeons, Dr. Herford or Dr. Moore. Other procedures that we typically do, kyphoplasty for vertebral compression fractures, and sympathetic ganglion blocks. Sympathetic ganglion blocks, stellate ganglion, lobar plexus blocks, celiac plexus blocks. Those are for more specific pain-related conditions, but the stellate ganglion can be used to treat non-pain conditions, such as post-traumatic stress syndrome. So that may be one of the unique situations where someone who doesn't have chronic pain may be seeing me. With that in mind, those are the treatment options that I have. My current clinic location is Center One on Centurion Parkway, but we are planning on opening a St. Johns County office coming soon in the near future, within the next month or two. If you want to get a hold of me, you can call me these numbers or send me an email. Was listed here. And with that, I'm going to open this up to questions and see if I can answer any of the questions you might have. I get that question a lot, particularly with the RFAs. We're burning this nerve away. Are you setting me up so that I'm going to injure myself because I don't feel it? I get that question a lot, and the answer is no. The answer is no. When it doesn't provide that level of numbness, that you're not going to know you're injuring yourself. And I would argue the other way, in that because the pain's not there, you're able to do those maintenance exercises that we talked about. Motion is lotion. So you keep that movement going, and you actually improve your long-term status. Typically, we want you to do a 4 to 6 week program of physical therapy before we tried. Now, the caveat being, if physical therapy is making it worse and you can't tolerate it, that we might adjust those numbers a little bit. But in general, it's that 6 weeks period. Well, that's typically done in a combination of ways. Physical exam being the first, but if we're confused and we don't really think, sometimes people can have both joint pain and nerve pain, but typically it would be a response to the treatments that we adjust. If we thought it was axial pain, we would try that facet joint injection. If that reduced your pain, then we would know it would be joint pain and not nerve pain. and vice versa. My policy is that I don't see patients younger than 10 years of age. I'm not a pediatric specialist. But beyond 10, I definitely would treat. My treatment approach is definitely going to be different in someone who's young than old. They're going to have less degenerative changes, and I in general would be less likely to offer some more invasive treatments because generally they'll improve on their own with some of the conservative measures. But depending on the exam and the imaging findings, all the interventions are on the table, and I don't think any particular age tends to respond better to treatments. Well, that often happens. I mean, we'd like to be 100% correct when we're working you up and doing these diagnoses, but often we're not. And sometimes, like I said, there can be more than one thing going on. So if we try something and it doesn't work, we reevaluate, and then where that evaluation takes us, we might try something else. For example, someone comes in with lower back pain along their lower back. We think it's facet related pain. We try a facet block, and it doesn't seem to help as much as we thought. And then we do a new examination, and it seems that the pain's a little bit lower. There's some physical exam suggesting sacroiliac pain. And we might try to address the SI joint as the pain source. Well, when we're talking about a all-inclusive comprehensive pain medicine plan, again, the long-term things that you need to do are those things that I talked about: the self-care piece, the activity modification, the core strengthening, making sure you're doing those physical things to keep you optimized. Those are the most important things long-term. Apart from that, it would depend on the individual treatment strategy or what condition that you have.